I'm an endocrinologist. I'm an endocrinologist at Newton-Wellesley Hospital. It gives me a great pleasure to be back on the Lunch and Learn series. And today's topic is on adrenal insufficiency. Before I get started, I would like to take a few minutes to introduce my colleagues to you all. We all specialize in general endocrinology, as you know, and we have our own areas of interest and expertise. In that context, Dr. Stapel-Resnick is the chief of the Division of Endocrinology at Newton-Wellesley Hospital and the director of the Diabetes Clinic, and her interests are around diabetes care. Dr. Eric No specializes in neuroendocrinology. Dr. David Slovic specializes in osteoporosis and calcium bone disorders. My areas of interest revolve around care of diabetes in young adults and post-transplant diabetes care. Dr. Sain If specializes in thyroid nodule evaluations, and we have two new endocrinologists in our clinic, Dr. Chung, who specializes in osteoporosis management, and Dr. Norman, who is soon to start, also specializes in general endocrinology. So with that, I'm going to start my talk here. Today's topic is on adrenal insufficiency. The key take-home points are the following. Iatrogenic adrenal insufficiency is not uncommon. Adrenal crisis has high rates of recurrence and mortality. Patient education on sick day triggers and stress dosing of steroid therapy to prevent adrenal crisis can be life-saving. My presentation format will be as follows. I will start with a very brief clinical scenario and dive through the anatomy and physiology of adrenal glands and regulation of hormonal secretion. Then I will discuss about the causes, symptoms, and signs of adrenal insufficiency, the key diagnostic tests that we use in our clinic, and how to guide patients on sick day management and stress dosing of steroids. A common clinical scenario that we all see in our clinic is, for instance, a 38-year-old patient with symptoms of fatigue, dizziness, and the patient asks, do I have adrenal fatigue? And on exam, the patient has orthostatic blood pressure changes, and lab may be evident for hyponatremia, sometimes hyperkalemia. With this patient in mind, let's take a look into the adrenal anatomy. Adrenal glands, otherwise known as the suprarenal glands, are located on the top of the kidney, and they have two main parts to them, the inner medulla that secretes the catecholamines and the outer core, which is the adrenal cortex that has three different layers, zona glomerulosa that releases aldosterone, zona fasciculata that secretes glucocorticoids, and zona reticularis that secretes the sex steroids. It should be understood that the regulation of cortisol secretion varies significantly from that of aldosterone secretion. Various stresses such as hypoglycemia, hypotension, fever, and also diurnal rhythm influences the hypothalamus to release corticotropin-releasing hormone, which works on the corticotropes in the pituitary gland to release ACTH, which in return stimulates zona fasciculata and reticularis to release cortisol and DHEA. Whereas aldosterone secretion is primarily governed by blood volume. And when there is a decrease in the volume status, there is activation of the renin-angiotensin-aldosterone pathway, which results in retention of sodium and water and excretion of potassium. The causes of adrenal insufficiency could be primary, where the problem is in the adrenal gland. It could be secondary, where the problem is in the pituitary gland, or tertiary, where there's a problem in the hypothalamic pituitary communications, specifically on the corticotropin-releasing hormone level. The most common inherited cause of primary adrenal insufficiency is congenital adrenal hyperplasia. We often encounter patients with autoimmune adrenalitis, and there are other causes of primary adrenal insufficiency highlighted on this slide. In the interest of time, I'm not going to go into the specifics of autoimmune polyglandular syndromes, but APS type 2 is commonly seen in the adult clinic, and it's associated with primary adrenal insufficiency, autoimmune thyroid disease, and type 1 diabetes. When we see these patients in clinic, we should take into account that they may have other autoimmune conditions, and the antibody that we test is 21-hydroxylase antibodies. These days, with the advent of checkpoint inhibitors for management of cancers, we are seeing a rise of secondary adrenal insufficiency where there is a problem in the pituitary gland, and this is immune-mediated hypophysitis. I would like to draw your attention to tertiary adrenal insufficiency, which is most commonly due to iatrogenic cause. That is, various medications that we use or patients use over the counter that can result in adrenal insufficiency. And this is very important to keep in mind when we see patients in the primary care clinic or our outpatient setting. Some of the patients who use Megace, which is megestrol acetate, a progesterone compound, can end up with adrenal insufficiency as it has glucocorticoid stimulatory effect and thereby causes tertiary adrenal insufficiency. There have been some studies in patients who use marijuana heavily that there is a blunted ACTH and cortisol reactivity in response to acute stress, and the hypothalamic pituitary axis in these patients perhaps might be dysregulated. Opioids are commonly prescribed medications in this country, and these opioids act on opioid receptors, primarily the mu, delta, and kappa receptors, which are G protein coupled receptors that are also located on the hypothalamus and pituitary gland. Endogenous opioids exert tonic inhibition on the hypothalamic pituitary adrenal axis, and the prevalence of adrenal insufficiency in patients who use long-term opiates can be as high as 29 to 30%. This is an analysis of 74 articles and included 3,753 patients to evaluate the outcome of adrenal insufficiency in patients who were prescribed glucocorticoids. The primary outcome was to see the percentage of patients who developed adrenal insufficiency after steroid treatment, and the article also included several secondary outcomes. In the interest of time, I'm not going to go into the details of how this study was done, but there are some take-home points that I would like to highlight. So they categorized the strength of steroids depending on what route it was and what was the dose of the steroids used. And the percentage of adrenal insufficiency in those who were prescribed oral glucocorticoids was 48.7% and 52.2% for intra-articular glucocorticoid administration. The percentage of adrenal insufficiency also depended on different types of chronic health conditions that the patients were treated for. And the study further evaluated to see how long the adrenal insufficiency persisted after stopping the glucocorticoid therapy. For instance, in this part of the slide, you can see that patients who were on long-term, that is greater than 1 year, and medium dose of steroids had persistence of adrenal insufficiency even 6 months after. That is 25% of these patients had adrenal insufficiency. So the authors concluded that adrenal insufficiency occurs frequently after discontinuation of glucocorticoid therapy. There is no single administration form, dosing, treatment duration, or underlying disease for which adrenal insufficiency can be excluded with certainty. Therefore, the threshold to test for adrenal insufficiency should be low in those with non-specific symptoms. There are several other medications that can affect adrenal function. I would like to get your attention to the over-the-counter adrenal supplements that our patients use. And these are vastly available as listed here. And they are basically animal products with adrenal cortex, which contain glucocorticoids, or they are liquor-rich supplements which inhibits the specific enzyme 11-beta-hydroxysteroid dehydrogenase enzyme that is important for inactivation of cortisol. So in this process, cortisol is not inactivated, and therefore the level of cortisol in the blood goes high, and patients develop tertiary adrenal insufficiency. So these are very important aspects for us to keep in mind and ask patients if they are taking any medications for fatigue symptoms, any over-the-counter herbal supplements, and to provide the supplement facts on these. Let's take a look into the symptoms of adrenal insufficiency. This was described by Dr. Addison himself in London Medical Gazette in 1849. And I would like to specifically read this part of his note here, where he says, I would like to direct your attention to anemia, general languor, debility, remarkable feebleness of heart's action, irritability of stomach, and peculiar change in the color of the skin, and so on. He was actually studying 11 patients in whom he thought there was B12 deficiency due to pernicious anemia, and he was trying to locate the problem, the anatomic site of problem for B12 deficiency, and he thought that this was coming from the adrenal glands, where he was actually describing symptoms of primary adrenal insufficiency. So these include the clinical manifestations of primary and secondary adrenal insufficiency, and the ones highlighted in yellow color here are the hyperpigmentation, hyperkalemia, and hyponatremia, which are specifically seen in primary adrenal insufficiency. These are pictures of patients who have the hyperpigmentation, as you can clearly see here. Let's quickly take a look into the tests that we do in the clinic and in our infusion center for evaluation of adrenal insufficiency. We can test random cortisol, AM cortisol, and cosentropin test. How do we interpret AM cortisol? So patient comes to the clinic fasting in the morning, nothing to eat, and we check the cortisol between 7:30 to 9 a.m. And if the cortisol level is less than 3 microgram per deciliter, for sure the patient could be adrenally insufficient, especially in a high clinically suspicious case. If the cortisol level is greater than 18 microgram per deciliter, we can say that the patient is most likely adrenally sufficient, taking into account the cortisol binding globulin status and the illness status in these patients. There are several guidelines with different cutoffs, and in general, we could say that anyone with a level greater than 14.5 microgram per deciliter perhaps is sufficient. And random cortisol also aligns along the same lines. Once we suspect that the patient may have adrenal insufficiency, we can do further evaluation with cosentropin test. And this is done in our infusion center. I will show you how to order the cosentropin test in one of these slides. In this test, patient is injected 250 micrograms of cosentropin, and we measure baseline cortisol, 30-minute and 60-minute changes. And if the cortisol is less than 18 at 30 or 60 minutes, then we can say that the patient has adrenal insufficiency. Or if it is greater than 18 at 60 minutes, then the patient has adrenal sufficiency. Once we prove that the patient has adrenal insufficiency, we test ACTH to guide where the problem is. Is it a primary problem where the ACTH is high? Is it a secondary problem where there is a non-elevated ACTH with failed cosentropin test? Or is it a tertiary problem where the patient has low cortisol and low ACTH? We could also test the aldosterone at the same time when we do the cosentropin test. This slide then dives through the various aspects of evaluation of causes of primary adrenal insufficiency, and you can take a look at it at your leisure in the interest of time for today's talk. So let's jump into the treatment of adrenal insufficiency. In patients who have primary adrenal insufficiency, the standard replacement dose is as follows. For glucocorticoid therapy, hydrocortisone is given at a dose of 15 to 25 milligram in 2 to 3 divided doses per day. The highest dose should be given in the morning at awakening, and the rest of the dose should be split either 2 hours after lunch or in the afternoon time. We can monitor therapy based on clinical symptoms, and the goal is to avoid undertreatment, adrenal crisis, or overexposure. For patients in whom we suspect primary adrenal insufficiency and mineralocorticoid deficiency, we start treatment with fludrocortisone, 50 micrograms. And once again, we measure the response to treatment with blood pressure changes, clinical symptoms, and labs. In pregnancy, it is important to take into account that the hydrocortisone dose should be increased in the 3rd trimester. Dexamethasone should not be used as it is not inactivated by the placenta, and hydrocortisone stress dosing should be started during the active phase of labor. Adrenal crisis is a very important topic for all of us to keep in mind when we see patients with adrenal insufficiency. Endocrine Society describes this as a medical emergency with hypotension, abdominal symptoms, and lab abnormalities requiring emergency treatment. And this slide further depicts what symptoms the patients might present with. And the common triggers could be gastroenteritis, other infectious process with fevers, emotional stress, pain, and so on. The immediate treatment for adrenal crisis is parenteral injection of hydrocortisone, followed by hydrocortisone 200 milligrams in divided doses over a period of 24 hours. It's very important for us to educate our patients on sick day management. For instance, a patient with adrenal insufficiency has fevers. And what should that patient do? We should educate the patient to either double the dose or triple the dose, depending on the degree of fever. And if they have vomiting or diarrhea, or in a state where they are not able to absorb the hydrocortisone orally, we should educate them to take hydrocortisone by intramuscular route or dexamethasone by subcutaneous or intramuscular route. We should also educate the patient to have a steroid emergency card. This is available in rest of the world, in the UK and Europe. There is also emergency med bracelets that we could provide the patients with and educate them on how to use parenteral steroids. We should also guide the medical team and the patients on perioperative stress dosing and how to prevent adrenal crisis. For dental procedures, we recommend patients to take an extra dose on the morning, 1 hour before the dental procedure, and double the dose for 24 hours and then return to the baseline. And for minor to moderate surgical stress, we can divide the dose between 25 to 75 milligram, depending on the level of stress. For major surgery requiring general anesthesia, we recommend patients to have stress dose of steroids, that is hydrocortisone 100 milligram IV bolus, followed by continuous infusion of hydrocortisone 200 milligrams per day, either through a drip or by parenteral route every 6 hours. When we see these patients in the clinic, it's very important to encourage adults and children with primary adrenal insufficiency to be evaluated by an endocrinologist or a healthcare provider with endocrine expertise annually for symptoms and signs of over and under replacement. Periodic screening for autoimmune diseases is also important. We should discuss about the possibility of thyroid disease, diabetes mellitus, premature ovarian failure, celiac disease, and autoimmune gastritis, along with B12 deficiency in these patients. We should educate patients about increasing the dose of glucocorticoids during intercurrent illness, fever, and stress. And finally, this is a slide on how to order cosyntropin test on EPIC. So we go under therapy plans and select the endocrinology bucket. And under this, we have 29 available options. So we click on that, and here you see the cosyntropin stimulation test. So when we select that, this kind of a tab will open up, and we'll have to enter the date as, for instance, today as the start date and the department that you belong to. Then the treatment plan will open up, and you can select the cosyntropin test and the medication, which is cosyntropin 0.25 milligrams, which is given intravenously, and the types of labs that you might order. I generally order a baseline cortisol 30-minute and 60-minute with a basic metabolic profile. And that's the main content of today's talk. I would now open up to some discussions and questions that you have. I really wanted to give a gist of how we manage patients with adrenal insufficiency and what to watch out for when patients come to our clinic, especially with symptoms of fatigue and taking over-the-counter supplements in order to understand the possibility of iatrogenic adrenal insufficiency, and raising our awareness on adrenal crisis and how to prevent adrenal crisis. Thank you so much for giving me this opportunity, and I will open up the stage now for questions.
All right, so I have one question. I think that some of the data around the iatrogenic, causes of adrenal insufficiency is fairly new. I know we're seeing some data, because I happen to be med-peds, we're seeing some data in pediatrics as well with children who are treated with recurrent doses of steroids, but I don't know that there's a lot of guidance from our staff for the primary care standpoint as to when we would refer to endocrinology, when would be the threshold, like how far do we take the workup, what would you recommend as far as, if I have, let's say I think it might be adrenal insufficiency, how far should I take it before I sort of involve you or your team?
Of course, it depends on how sick the patient is. If you have a high degree of suspicion and you're uncomfortable in evaluating and ordering a cosyntropin test, which I hope this talk has helped to some extent, then definitely, patients should be seen by endocrinology or, sent to the hospital for evaluation. But if the patient is fairly stable, vitals are stable, you could start with evaluating with an AM cortisol, You could also consider doing a cosentropin test, as I indicated on the infusion center list. I also see a lot of questions on e-consults these days, and which we are happy to help through. So that's how I would, evaluate. I think, primary care physicians are getting more and more comfortable with evaluating patients for possible adrenal insufficiency.
And so from your experience, if you're expecting these patients with iatrogenic adrenal insufficiency somewhat rebound after a certain time period, what situations would you start, let's say, putting them on a taper or something like that, based on their symptoms? Most of these patients don't come in crisis. They're usually just vague symptoms that we hear about, which many patients have. So I just wanted to sort of get a sense of, from your standpoint, where is your sort of point of pulling the trigger of treating this versus watching for rebound?
So I think when you have a high index of suspicion, you should evaluate them and then treat them with replacement. So I would start with, what is the index of suspicion? And then you confirm the diagnosis and then you treat. But if they are very sick, if they have hypotension, they have nausea, vomiting, and they require fluids, definitely I would send them to the hospital and have patients get evaluated in the hospital. I don't know if my colleagues have a different viewpoint in terms of answering this question.
No, thank you, Kavita. I think that was great. Eric, did you want to add something?
I think I was just going to clarify, is the question like someone who's on steroids and you're trying to get them off of steroids and they're having problems getting off because of symptoms of adrenal insufficiency, or someone who's been on long dose steroids and you stopped it recently and then they're having symptoms?
I think that, I guess my question was more along the lines that there's data out that says that people who might get recurrent doses of steroids for whatever reason, asthma or COPD or whatever the case might be, that they may actually experience adrenal insufficiency, right? And the expectation in that situation is that they will rebound after a certain period of not getting steroids or, that type of thing, because the data shows that sometimes with short courses, they eventually rebound. And I guess my question is, when the patient's symptomatic but not an adrenal crisis, we might think of doing an evaluation. Where's that trigger point for starting treatment for adrenal insufficiency and determining, how long you would wait before you'd see if they would rebound, let's say, from suppression from, let's say, iatrogenic, steroids. Does that make sense?
I just want to make sure, rebound meaning they start having symptoms of adrenal insufficiency?
Like that they're innate, their own, system.
They're recovering.
Yeah, exactly. Right.
Got it. Yeah. I mean, so yeah, if people, at least how I do it is if people have been on, steroid injections for back pain, they're getting something like every 3-month injection. So they're getting like 4 injections a year, 5, 6 injections or more, because I find that people don't really keep track of how many injections they're getting. Like they get one for the knee, they get one for the shoulder, they get some for the back, and then, or on, high doses of inhalers or something like that. If they have symptoms of adrenal insufficiency, I cord stim them. And if their cord stim comes back positive for adrenal insufficiency, and in a clinical context of them having symptoms and having had, steroid use, even if it's just not oral steroids, of course, with its oral steroids, it becomes more obvious, but then I treat them. And I usually put them on prednisone as low dose as I can. To basically make the symptoms go away. So I typically use 3 to 5 milligrams. If they're a little bit bigger, I start at 5. If they're smaller, I start at 3. And then I'm going to inch that steroid dose down as much as I can. And if it's something like asthma, right, where it's an inhaled steroid and that inhaled steroid dose doesn't go down, then I don't know if I'm ever going to get them off replacement doses of prednisone. If it's something like steroid injections, then I tell them, you got to find something else. I say that hesitantly because obviously they're in a lot of pain. But I try to tell them you got to try to find something else because this is causing a problem with the adrenal insufficiency. And hopefully they can have less injections. Then I just keep bringing their prednisone dose down. Usually once I get to about 3 milligrams of prednisone for months on end that I've kept them there, they're doing well, I'll stim them again. And if they pass the costentropin stim test, then I'll taper rapidly.
That's helpful. Thank you. Are there any other questions? I don't see anything in the chat. All right. I think that's it then. Well, thank you so much for your help and this wonderful talk, Dr. Sitharaman, and everyone else. Have a great day.
Thank you so much for the opportunity.